Hi, my name's Anthony Marin. I'm a certified specialist in reproductive endocrinology and infertility in private practice with Genea. Today's video is on pre-implantation genetic testing, which is becoming more and more common in the IVF arena. Before we talk about pre-implantation genetic testing, it's worthwhile going through the basics of chromosomes and genes. A really useful website is genetics.edu.au. They have really good fact sheets on a whole lot of different genetic conditions and basic information. It's probably easiest to think of all of our genetic information organised as basically like a set of encyclopedias. And the chromosomes that are in each of our cells, each of the chromosomes is like one volume of a set of encyclopedias. And essentially we have 22 pairs of standard chromosomes, one pair from our mum and one pair from our dad, and the final pair of chromosomes is what's known as the sex chromosomes, so XX for female, XY for male. So there's 23 pairs in total. Now a gene is found on chromosomes, and essentially it's like a page out of one of the volumes of encyclopedias. And so for instance, the gene that encodes for the cystic fibrosis mutation may be just one page. Now the error that can cause a genetic condition can be down to a simple spelling mistake on that one page. And it's just important to understand the difference between what's a chromosome and what's a gene and what an error is. In regards to pre-implantation genetic testing, this is broadly divided into pre-implantation genetic diagnosis, or PGD, and pre-implantation genetic screening, or PGS. PGD is used in high-risk couples, and that's where one in the couple either has a genetic condition or both of the couple are carriers, and there is a specific risk that their offspring will also be affected by the condition in question. Whereas pre-implantation genetic screening, we're not looking at the gene level, we're really just looking at the chromosome level, and we just basically want to make sure that our embryos have the right numbers of chromosomes and that they're appropriately ordered. Now, some people will be keen to do pre-implantation genetic screening, such as an older woman going through IVF, or couples who have done multiple rounds of IVF without success, or couples who have had recurrent miscarriage. But more commonly, it's becoming something that's fairly typical that all couples that are going through IVF will often want to screen their embryos to make sure that they're chromosomally normal. It is important to note that the difference between the two is that pre-implantation genetic screening looks at the chromosome level, whereas PGD is really looking at the gene level. So the technologies are slightly different and they give you different information. In terms of pre-implantation genetic testing, there's a whole team of people working to try and give you the best result. So in addition to your fertility specialist, it can often also include the geneticists, the embryologists, the PGD scientists, and the counsellors. In terms of pre-implantation genetic diagnosis, this is done where one in the couple either has the genetic condition in question or both are carriers, and therefore there is a specific risk that any offspring will be affected. With PGD, we're looking at the gene level to work out whether or not the embryo has inherited a gene that is affected or not. Usually we would combine PGD with PGS, because if we are going to look at the gene level, we also want to make sure that the embryo is otherwise chromosomally normal and has the correct set of chromosomes and they're appropriately ordered in order to maximise the chances of a successful ongoing pregnancy. In terms of a PGD cycle, there is an initial meeting with the geneticist and the PGD team, just so that you as a couple completely understand the process and specifically understand the limitations of the process. In terms of the cycle itself, we usually use a slightly higher dose of medication in order to maximise the number of eggs that are recruited and hopefully get greater number of embryos suitable for testing. Instead of doing IVF for fertilisation, where you just put a whole lot of sperm with the eggs, we usually want to do ICSI for fertilisation, and that's where the scientists inject a single sperm into the egg, and that's in order to reduce the probability of contamination so that the results that we get are as accurate as we can get. When the reports come out, the scientists will actually provide you with a level of accuracy, and that's typically somewhere around about 98 to 90%, 99% in terms of their confidence that the results that they are providing are correct. In terms of pre-implantation genetic screening, this is either done because the couple are specifically concerned that their embryos may be at a higher risk of having chromosomal problems. For instance, women who are a little bit older, women who have had multiple cycles of unsuccessful IVF or recurrent miscarriage, or more commonly, this has now been done almost as a routine in an IVF cycle. Essentially, with an IVF cycle, it involves stimulating the ovaries, collecting the eggs and the sperm, bringing the eggs and sperm together and growing them as embryos, transferring an embryo back, and then waiting to see if the cycle is successful or not. Now the big thing is what limits success. And Genea has undertaken a study where they've looked at 54 couples who have had multiple embryos back and they haven't worked, and they biopsied over 160 embryos. They found that over 40% of the embryos that were suitable for freezing were actually chromosomally abnormal. So there was either an additional chromosome or a loss of a chromosome. In about 55% of cases, there was one chromosomal error. Interestingly, in about 40% of cases, there was two chromosomal errors, and in the remainder, there were more than three chromosomal errors in that embryo. And in that situation there, either an embryo would go back, and most commonly it won't work, or the embryo could go back and will implant but fail, or more importantly, the embryo could go back and you'd find out that there was a problem around the time of the first trimester screening. So IVF with pre-implantation genetic screening tries to improve your success with IVF, and it does this by not transferring embryos that we know to be chromosomally abnormal. The IVF cycle is largely the same in that the eggs and sperm are brought together and embryo development occurs in the lab. The differences from a lab perspective is that we normally undertake a process called assisted hatching, and that's where the scientists use a laser and they put a small hole in the protective shell around the embryo. And the assisted hatching can be done anywhere from roughly day 3 onwards. As I explained in the video on the IVF cycle, around about day 5, the embryo is called a blastocyst. It's over 100 cells, and it's divided itself into 2 groups of cells. There's an inner group of cells called the inner cell mass, and that group goes on to form the developing fetus. And then there's an outer layer of cells, what we call the trophectoderm, that forms the future placenta. Because we've undertaken that assisted hatching process, we hope that those cells that form the future placenta herniate or hatch out through that hole, and therefore it enables the scientist to come along and take off somewhere between 3 and 6 of those cells without harming the embryo, so that you can test those cells to make sure that the embryo is chromosomally normal. That process is known as the embryo biopsy. When those cells are then tested, it takes some time, and it takes about 2 to 3 weeks, and therefore the embryos need to be frozen. And usually what will happen is I'll get a report about 2 to 3 weeks later, and we can work out which embryos are normal, which ones aren't, and only transfer a normal embryo back. With a PGS cycle, you have the option of either transferring your fresh, untested embryo and biopsying and freezing the remainders, or you can choose to biopsy and freeze all embryos. This decision largely depends on your clinical history, and so for instance, if this is your first IVF cycle with no history of miscarriage, most people are usually happy to transfer a fresh untested embryo. If, however, you've had a few cycles that have not been successful, or you've had miscarriages in the past, then you may choose to biopsy and freeze all embryos. The differences between PGS and PGD is we're less fussed about the method of fertilisation, and at Genea we are actually happy to do IVF for our PGS cycles, as we know that our IVF embryos is less invasive to the egg. We tend to get better embryo development and better pregnancy rates as a result. The accuracy of PGS is reported at roughly around about 95%. So that does mean that you will still need to have some discussion around about first trimester screening. It is important to realise that sometimes, despite all the best efforts of the staff, that no results are available. Sometimes there's even a misdiagnosis, and sometimes all embryos are deemed abnormal. The final thing to discuss with this video is something known as mosaicism. And mosaicism we've known about for a long time, but with the newer technologies that we're using, we're seeing it more frequently in our embryos. Mosaicism just basically means that when the 3 to 6 cells that are taken from the embryo are tested, some of those cells are normal and some are not. And so we're seeing a mosaic pattern. The issue with mosaicism is that when we do the biopsy, we're only biopsying a very small percentage of the embryo, so it's really hard to know how representative of the whole embryo that picture is. And the second thing is we're only biopsying the cells that form the future placenta, so we actually don't know what the cells that form the future fetus are. So if we transfer a mosaic embryo, there is a good chance that it will implant and lead to a completely normal, healthy pregnancy. However, we do know that with mosaic embryos that they have a lower implantation rate, they have a higher miscarriage rate, and if a mosaic embryo leads to an ongoing pregnancy, then there does need to be genetic counselling in terms of what could be some potential risks for that baby, and often we would suggest amniocentesis. So if you undertake PGS and a mosaic embryo is found and you wish to use a mosaic embryo, we would normally strongly suggest careful genetic counselling prior to that embryo transfer. Thank you for watching today's video on embryo testing. For further information, feel free to look at our website marioncampbellmackie.com.au or phone the displayed number for an appointment. Thank you.